disorders. Diagnosis will have prognostic and treatment implications. Risk factors of dementia include age, usually above 60, gender, mostly males, and genetics and family history, like in CADASIL, that is a type of dementia, inherited dementia. They have a family history, strong family history. It is autosomal dominant, and the short form for cerebral autosomal dominant arteriopathy with subcortical infarction and leukoencephalopathy. Smoking is a risk factor, prior strokes, heart diseases, alcohol abuse, atherosclerosis, dyslipidemia, diabetes, and various other yet under study. And regarding Alzheimer's dementia, Down syndrome is also a risk factor, and estrogen and NSAIDs are probably not. These are controversial risk factors. There is certain cognitive decline occurring with advancing age, which is characterized by mild changes in memory and rate of information processing, but this impairment is not progressive and does not interfere with daily function. In the diagnostic criteria for dementia, one thing should be very clear, that dementia is not only impairment of memory. It involves several other aspects of cognition as well. This slide is about DSM-5 criteria of diagnosis of dementia. Memory impairment is one. Impaired ability to learn new information or to recall the old information, that is called memory impairment, and the patient should have one or more of the following: aphasia, language disturbance, apraxia. As you all know, we have discussed in detail about apraxias and agnosias in our lecture in lesion localization, which is impaired ability to carry out the motor activity despite the intact motor function and sensory function, and disturbance in executive functioning, that is impaired ability to plan, organize, sequence, and abstract. The cognitive deficits result in functional impairment, which is social as well as occupational. The cognitive deficits do not occur exclusively and solely during a delirious state, and they're not due to other medical or psychiatric conditions. So these diagnostic criteria have to be met before we diagnose any patient with dementia. What are the activities of daily living? There are simple activities of daily living like bathing, toileting, transfer, dressing, and eating. And there are instrumental activities of daily living which involve executive functioning and which include maintaining the household, shopping, transportation, and managing the finances. Now, what is delirium and what is depression? These are often confused with dementia. Delirium is an acute clouding of sensorium or consciousness with fluctuations in the level of consciousness, and the patient has difficulty with attention and concentration. There are multiple causes of delirium, which include infectious causes, which can be CNS infection, which can be any systemic infection, especially in old age patients, like they can develop delirium even with simple urinary tract infections and also pneumonias. And there are certain metabolic disturbances which can also lead to a delirious state, including hyponatremia and hypercalcemia. And then depression patient may also complain of memory loss. Now, how would you determine whether it is a true memory loss or it is just a subjective complaint? Usually, those patients who have true dementia, they themselves don't initially notice that they have any problem with their memory or functioning. Their caregivers, the attendants, the patient's friends and family, they notice about it first before the patient notices anything abnormal about himself. But that is the other way around in the patients of depression. Family or friends do not notice any abnormality, while the patient comes and complains that he has memory impairment, and there will be presence of symptoms of depression. And the delirium and depression, they can even be markers of dementia. They can be symptoms of dementia. Okay. There are 5 major types of dementias. Most common one is Alzheimer's disease, that is 60 to 70%. Then we have cerebrovascular or vascular dementia, that is 15 to 25%. And then we have Lewy body dementia, 5 to 8%, frontotemporal dementia, 3 to 5, and the less common is the Parkinson's disease with dementia. It's estimated by 2040 about 120 million of the population will be suffering from dementia. Prevalence is 6 to 8% in 60 years and doubles every 5 years. At 80 years, 47 to 50% of population suffer from some form of dementia. Now, we divide the symptoms into mild, moderate, and severe. The mild dementia symptoms include disorientation for dates, naming difficulties, difficulty in naming the objects, recent recall problems while the remote memory is intact, difficulty in copying figures, decreased insight, social withdrawal, patients tend to be isolated, tend to be disinterested, irritability and mood changes that may be including depression or irritable mood, and problems in managing the finances, counting, managing the finances, keeping record and all. Moderate dementia symptoms include disoriented to date as well as to place, comprehension difficulties, they have difficulty in understanding, impaired new learning, they are unable to or there's difficulty in learning new things, getting lost in familiar areas like forgetting the path back to the home, forgetting the familiar paths while they drive, or impaired calculating skills. Delusions, agitation, aggression all can occur. They have problem in shopping, banking, cooking, carrying out the recipes, the learned recipes, and restlessness. The patient can be restless, anxious, as well as depressed, and they may face problems with dressing and grooming. In severe dementia, the speech is unintelligible, is very difficult to understand. Remote memory is also lost along with recent memory. Inability to copy or write. There is loss of self-care. Patients, they are unkempt, they stop caring about their self-hygiene, and they also become incontinent. In Alzheimer's disease, 60 to 80% they are in older patients. There is memory loss, personality changes, global cognitive dysfunction, and functional impairment. Onset is mostly after 65, and it is more and more common with more advancing age. Visual spatial disturbances are an early finding, as I have mentioned in my lecture in lesion localization. These skills, they are a cognitive process necessary to identify, integrate, and analyze the space and visual form, details, structure, and spatial relation in more than one dimension. Now, these skills are needed for movement, depth and distance perception, and spatial navigation, especially like driving and moving around. And impaired visual spatial skills can result in poor driving ability because distances are not judged correctly, or difficulty navigating in space, such as bumping into things. Then we have apraxias, agnosias. You all are aware of these terms. Language disturbances, personality changes, as I've already mentioned. Either patient can have depression or they can have irritable mood, and delusion and hallucination usually occur late in the course of the disease. Depression occurs in 1/3, delusion and hallucination occur in 1/3. Absence of focal neurological sign. Now, there is little explanation needed regarding absence of focal neurological signs because, as you know, in advanced age, strokes are also very common, especially when the patient has risk factors. So it's very difficult to say that absence of focal neurological sign. A patient of a stroke can develop Alzheimer, and a patient of Alzheimer's disease can develop a stroke. So these both things can overlap, and this needs a good history and maybe workup. EEG is normal either, or it is non-specific. In histopathology, there is extracellular deposition of amyloid-beta protein, intracellular neurofibrillary tangles, and loss of neurons that is found in autopsy. Then we have another dementia, which is vascular dementia. Onset of cognitive deficit is associated with stroke, but many a times there is no clear history of a stroke, and there are multiple small asymptomatic undiagnosed infarctions, and when the deficit accumulates, then the patient starts to deteriorate and develop symptoms. There can be abrupt onset of symptoms with stepwise deterioration. Findings on neurological examination are present, including motor deficit. There can be extensor plantars. There can be other findings, again, spasticity, hyperreflexia. Infarctions are found in cerebral imaging, but CT-MRI findings often have no clear relationship with the severity of the disease. And sometimes what happens, there is overlap. Again, same thing, old age, risk factors, infections, risk factor for vascular dementia, old age again a risk factor for Alzheimer type. So sometimes both these dementias overlap and one patient can have both. Likelihood of Alzheimer and vascular disease, it increases with age, therefore likelihood of both of these dementias as well. Vascular risk factors, they predispose to Alzheimer. Does it allow the symptom of Alzheimer to be unmasked earlier? May or may not be. And this is imaging in vascular dementia. This is a CT brain which is showing prominent sulci and gyri suggestive of cerebral atrophy, and here you can see the hypodensities in the white matter. These are white matter ischemic changes, or what we call as small infarctions or small vessel disease. It's very clear in MRI brain T2 imaging, where you can see multiple smaller and also confluent areas of hyperintensity in the cerebral white matter, and there is prominent sulci gyri indicating cerebral atrophy. Then comes Parkinson's with dementia. 30% of the Parkinson patient disease, they may develop dementia. Age is usually 70 or maybe little less or little more. Cognition, there is memory problem, executive functioning problem, language issues, and orientation impairment. And they may have depression, they may have hallucinations. And neurological findings, you will find findings of Parkinson's disease, that is rigidity and slowing, bradykinesia. Maybe in advanced stage, patient may have problem in mobilizing himself. There may be tremors. And prognosis, once a patient of Parkinson's disease develops dementia, they usually die within 5 years. Then we have dementia with Lewy bodies. On histopathology, you will find cortical Lewy bodies. They can overlap with Alzheimer and Parkinson's disease. The main symptom of Lewy body dementia is hallucinations and fluctuations in the mental status, and they may appear delirious. So they may wrongly be diagnosed as having delirium. Delirium patients can also have hallucinations. So is true for dementia with Lewy bodies. They can be early delusions and hallucination, and even in these patients, you may get mild extrapyramidal sign like rigidity and bradykinesia. And they are neuroleptic hypersensitive. That's why antipsychotics or neuroleptics are usually avoided in these patients. And unexplained falls or transient changes in consciousness can also occur. Then we have frontotemporal dementia, which is 5 to 10% cases of dementia are because of FTD or frontotemporal dementia. Onset is in younger age group relatively, that is 45 to 65. Cognitive testing may be normal or minimally abnormal, especially in the initial period. Memory loss is usually not an early feature. There can be focal atrophy of frontal lobe along with or without anterior temporal lobe atrophy. Frontal lobe degeneration of non-Alzheimer disease type, that is, it lacks the distinctive astropath findings seen with Alzheimer's. May be autosomal dominant. In those cases, you will get family history. So there are two variants of frontotemporal dementia. One is behavioral variant and the other is primary progressive aphasia. In behavioral variant of frontotemporal dementia, they develop impaired executive functioning like initiation of an activity, goal setting, planning, and disinhibited behavior, like which is socially not acceptable. That is a disinhibited behavior, like removing clothes in front of the family members, urinating in public places. Usually these behaviors are not socially accepted. This is disinhibited behavior. And memory impairment can also be there. Then we have other variant of frontotemporal dementia, that is primary progressive aphasia. These patients, they slowly develop non-fluent anomic aphasia. They have problem in naming the objects with hesitant and effortful speech. Repetition, reading, writing is also impaired. Comprehension is initially preserved, but later on, comprehension can also be lost. It is slowly progressive. Initially, the memory is preserved, but 75% of these patients eventually develop non-language deficit. Most patients, they even become mute and they're unable to speak. Average age of onset of primary progressive aphasia variant is around 60 years. Then we have certain reversible causes of dementia. These are the causes which are treatable, and these are present in 10% of all patients. In reality, only 2 to 3% of most will truly have a reversible cause of dementia. These causes include medications, which can be medication overdose, which can be due to drug interaction, and one example is topiramate, which can cause cognitive impairment. Then comes alcohol abuse, and then we have nutrient deficiencies like B12, niacin deficiency. We have endocrine disorder like hypothyroidism. We have hepatic and renal dysfunction. These patients can also have cognitive impairments secondary to their underlying primary disease. Subdural hematoma patient can also present with decreased cognition. And then depression, as I have already told you, depression, pseudodementia can occur in depression. That is called pseudodementia. And it can be even an early symptom of true dementia. Then we have brain tumors, and they can also present with cognitive impairment. Frontal lobe tumors can present with personality changes. They are sometimes mistaken for having early Alzheimer's disease. Chronic subdural hematomas can be a cause. And then we have normal pressure hydrocephalus. What is normal pressure hydrocephalus? Normal pressure hydrocephalus is characterized by a triad, that is gait disturbance and urinary incontinence, and then last comes the cognitive dysfunction or dementia. The cause usually is a remote trauma, head trauma, or subarachnoid hemorrhage in the past, or some CNS infection in the past. And there is advancing hydrocephalus, giving this triad of the symptoms. There is ballooning of the frontal horns of the lateral ventricle, which compresses, have pressure effect on the frontal lobes, giving rise to gait disturbance and urinary incontinence, and gradually it progresses to cause dementia. That is diagnosed on neuroimaging, and we can use CT and MRIs. And for reversibility, to assess the reversibility, if this patient will respond to the shunt placement, or if it is due to NPH, the dementia is due to NPH, we do gait assessment before and after removal of 30 cc of CSF. We assess the patient, we make a provisional diagnosis, and we draw 30 cc of the CSF. We record their gait before drawing the CSF, and the gait is typically an apraxic gait that we also define as magnetic gait. There is problem in initiating the gait, and once they initiate, then they can walk. We remove 30 cc CSF. Before that, we record the gait of the patient, and after withdrawing 30 cc CSF after a few hours, we again record the gait of the patient, and we see and we compare if there is an improvement. And those patients who respond to CSF withdrawal, they usually respond to PP shunt placement for NPH. Radioisotope diffusion studies of CSF can also be done. Then we have some other infections which can cause dementias, or dementia is one of the symptoms of these infections. Syphilis, as you all know, tertiary syphilis can cause dementia, and HIV dementia complex is a well-recognized entity. And then we come to Creutzfeldt-Jacobs disease. It has different variants, and dementia is in the one variant. Patient may develop present with dementia and myoclonus, and there are other variants. There are psychiatric disturbances and seizures, and patient have motor signs and visual disturbances also. So there are some infections also which can present as dementia. Now, for assessing dementia, we use a scale that is mini mental state examination, and it is a 30 question scale, and 25 out of 30 is suggestive of dementia. Sensitivity is 87% and specificity is 82%, and there is some problem why it is 87% sensitive. I will explain it later. It is not sensitive for minimal cognitive impairment, and it is spuriously low in people with low educational level, low socioeconomical status, poor language skill, illiteracy, and impaired vision. Because when you will look at the questionnaire, you will know there are questions regarding calculation, in which we do the serial 7 minus from 100, and then we have commands like reading, writing, and following the written commands. If the patient is not literate, so there will be problem in assessing those commands. And if the patient is impaired vision, again there will be problem. Poor language skill, if the patient is not understanding your commands, then again there will be problem. So that's why the sensitivity is not 100%. And it's not sensitive in people with higher educational background, because they can use their skills to mask some symptoms. Additional evaluation is done by drawing the Clockface, and the short assessment with good validity include you just do 3-item recall and Clockface, and it has a quite good sensitivity. 3-item recall, like you tell them names of 3 objects, and how do you do it? You don't tell them to remember book, pencil, and pen. See, all these 3 items are related to each other. The items should be from different categories, and these should not be present around your patient's surroundings. You need to choose 3 items from 3 different categories. One is a fruit, maybe one is some educational material like a pen, pencil, or maybe a third one is an animal. So this is how you choose those 3 items, and then you ask them to recall after 5 minutes, and then you can ask them to do a Clockface. I think I've explained the Clockface trying in my lesion localization lecture. It's explained in detail. Then we do the neurological examination for focality. Focality means maybe patient has vascular dementia, maybe he has some motor deficit or extensor planters. We look for the frontal release sign like grasp reflex. We also look for jaw jerk. Can be present in vascular dementia. Patient may have multiple infarction in upper motor neuron signs including brisk jaw jerk. Apraxia can be present in primary as well as in secondary dementias. Cogwheeling can be present in dementia with Parkinson's disease and also in Lewy body dementia. Eye movements, there may be hypometric saccades and slowing of the eye movements in patients with Parkinson's. Lab testing and neuroimaging, again, there are certain causes which are reversible, and B12, thyroid levels, these should be seen, and neuroimaging in those patients where indicated. Apolipoprotein E epsilon 4 allele, this is done for Alzheimer's disease. Prognosis, previous estimate of median survival has ranged from 5 to 10 years, and prognosis again depends on type of dementia and the cause of dementia. Now, the management of dementia, goal of the treatment is to control and slow down the symptoms of dementia. Treatment depends on the condition causing the dementia. Again, if the cause is reversible, we need to treat the cause, and patient may improve significantly after removal of the cause. Some people may need to stay in the hospital for a shorter time. Now, stopping or changing certain medication which make the confusion worse may improve brain function. What are those medications? Anticholinergics. These can cause the decreased cognition, and even these can cause hallucination. Like topiramate, as I've already told you, can cause cognitive impairment. There are certain medications also. We need to review the treatment chart of the patients, and we need to remove those medications and to replace it with some suitable medication. Some kind of mental exercise can also help with dementia. As far as the management is concerned, we have non-pharmacologic and pharmacologic management of dementias, and cognitive enhancement through memory training, and it is done, which comes in the non-pharmacologic, and there is individual and group therapy in which we do emotional-oriented psychotherapy, stimulation-oriented therapy, art and exercises, and also we need to communicate with the family and the caregivers, because dementia patient, he not only suffers himself, but the family and caregivers also suffer. It's very difficult to deal with a dementia patient. You need to take the medical and legal advance directives, and there are some environmental modifications, like you need to do some memory measures, like patients, they can be given clocks and some measure to improve the memory. Calendars can be given to them. They need to maintain to-do list or some name tags or some alert bracelets and these kind of things to help them out regarding their memory issues. Pharmacological treatment, as far as it is concerned, it is an individualized treatment, and we need to monitor renal clearance and hepatic metabolism. Anticholinergic medication, they worsen the cognitive impairment, and these should be withdrawn when possible. We need to start low and go slow, and we need to avoid starting multiple medications together. Now, we have a class of medication which is cholinesterase inhibitors. Mostly it is used in Alzheimer's dementia, and it has certainly, or I must say, this is definitely probably no role in other type of dementias, only in Alzheimer's disease. One of these is donepezil. It is cholinesterase inhibitor, and titration is easy, dose is easy, once a day dose. We can start with 5 mg and we can proceed to 10 mg. The side effects are basically GI side effects, which include nausea and diarrhea. and it is associated with improved cognitive function, and the main effect is the lessening of the rate of decline, delayed time to needing nursing homes, and more intensive care. It may prolong, slow down the cognitive impairment in Alzheimer's disease. These are certain studies there are present which have assured this. And other agent and cholinesterase inhibitor group are rivastigmine and galantamine, but these have more side effects and more titration is required. And the easiest titration is that of donepezil. These are given in highly selected patients, like they are more effective in mild and moderate dementias and Alzheimer's, and they may lead to some quality of life improvement. And in severe dementias and mild cognitive impairment, the role is not definite, it is not known, and usually these are not used. Now for memantine. Memantine is used in moderate to severe Alzheimer's disease, in which the minimal score is between 3 to 14. And NMDA, it is an NMDA receptor antagonist, and it works on the theory that overstimulation of the NMDA receptor, maybe glutamate, leads to progressive damage in the neurodegenerative disease. And there was a study which was a 28 weeks double-blinded placebo-controlled study, and which showed that there is less decline in activities of daily living score and less decline in MMSE. Problem is that there is significant dropout. There was significant dropout in both the groups, and data analyzed it did not account for dropouts, followed those at risk. Silazepam, it has unclear benefit, less than 10 mg per day is the dose. It is a selective monoamine oxidase inhibitor, and there is some concept that it can be neuroprotective role, but the studies are not very conclusive. Then there are certain other supplements like ginkgo biloba. There was a systematic review of 9 double-blind RCTs with Alzheimer, vascular, or mixed dementia, and it was short duration. High withdrawal rates were there. In rest studies, they have shown no significant change in clinicians' global impression score. It means that the effect has not been very, very significant. But these things are being used. And along with that, other antioxidant, vitamin supplements, coenzyme Q10, these have also been used. But there is no definitive evidence that these have any significant effect on the cognition. And other treatment, there's no good evidence to support estrogens or NSAIDs for dementias. Then we have other issues as well. Despite this cognitive issues, memory issues, and activities of daily living impairment, patient may have behavioral problems, and these can be very, very troublesome. And we can have non-pharmacological strategies for that, and we have if the patient is not manageable, then he can be placed in a nursing home. If he is excessively agitated, if he is incontinent, there are falls, and the caregiver are so much stressed out that they cannot manage the patient at home. So these are the indications for nursing home placement. These behavioral symptoms can be managed with antipsychotics, commonly prescribed in older patients with dementia and behavioral problems. And choices include haloperidol, which is a typical antipsychotic, and the dose should be used at the lowest possible dose. It's 0.5 to 1 milligram, not more than that. And then we have other antipsychotics also, which come in the atypical antipsychotic group. One is risperidone, then we have olanzapine, quetiapine, and these antipsychotics in the big picture, when we see that concerns with the haloperidol for significant risk of extrapyramidal symptoms and tardive dyskinesia with prolonged use in the elderly. When you use for longer times, especially more than 3 months, they can develop extrapyramidal symptoms like rigidity and slowing of movements, and they can develop tardive dyskinesia, they can develop chorioacetoid movements, then these can be troublesome. All have risk of sedation, orthostasis, and varying amount of anticholinergic effect. These drugs do have anticholinergic effect. Studies show slight efficacy for behavioral problems in dementia, but these drugs are not FDA approved. And these drugs, they have advanced increased risk of death and stroke with use of atypical agents. Atypical agents, these can cause QT prolongation, especially in those patients who have risk factors for vascular disease like diabetes, hypertension, ischemic heart disease. They may have very high risk of death and maybe arrhythmias with these atypical antipsychotics. And antipsychotics should not be used if you are suspecting diffuse Lewy body dementia, because these patients, they are hypersensitive to antipsychotics. They can develop neuroleptic malignant syndrome if taken antipsychotics. There is an FDA warning, and the analysis of multiple placebo-controlled trials of elderly patients with dementia of the atypical agent demonstrated increase in the mortality already mentioned. They can lead to QT prolongation, and they can lead to arrhythmias, and they can even cause sudden death. It may also apply to older agents like haloperidol, but less so. Atypical agents are more associated with sudden deaths and cardiovascular mortality, especially in the old age. Caution is needed. The bottom line is that when you are using these drugs, a lot of caution is needed, and you need to weigh the risk-benefit ratio, always. The pharmacological treatment of vascular dementia, as you know, this is because of occlusion of the small vessel causing smaller infarctions. You need to correct the risk factors, control the risk factors like hypertension, diabetes. You need to adequately control hypertension, and if patient has dyslipidemia, you have to control dyslipidemia with the statins, and you need to do regular follow-ups. You need to give stroke prevention, that is with antiplatelets and the statin, and patient may have symptoms of depression. In that case, SSRIs can be used, memantine can be used. If patient has seizures, anticonvulsants can be used, and if they have behavioral symptoms, antipsychotics in low doses can be used. There are certain tips when you perform mini mental state examination. Serial 7 may be problematic for many patients, so you can ask them to count months backward, or you can ask them to count names backward, weekdays, name of the weekdays backward. This determines the assessment of attention. First of all, you need to assess patient's literacy before you start doing mini mental examination, so that you should modify it where needed. And you need to assess for dominant hand also prior to handling the paper over. There's a proper questionnaire, and you can download it from any good website, and you can look at it for the questions which are asked in the mini mental state. Basically, these are questions meant for orientation, and then we have questions for memory, in which we do the registration and recall, and then we have certain written commands to follow and reading. These all function are assessed in mini mental state examination. And you should not overread the patient, should not give excessive hints. 3-item repetition, repeating 3, then patient has also had to repeat all the 3 items before you ask them to memorize. The 3-stage command, you have to repeat all 3 parts of the command, and then the patient has to do it. So this was all about dementias and the assessment, mini mental state, and certain workup required. I hope it was comprehensive and enough at this level. If you have any question, you can always post.